vascular and cardiovascular events. And that is also studies are there and clinical trials also are there. So generally we are using rivaroxaban 2.5 BD and aspirin 75 OD. So revascularization main goal is to restore the adequate blood flow to promote wound healing and prevent amputation. And limb salvage improves from 50 to 90% when timely revascularized. And the question is that how many arteries to treat? So in severe claudicant or rest pain, the revascularization of the inflow arteries, aortoiliac and femoropopliteal segment with single BTK runoff. If minor tissue loss, then we can treat according to angiosome concept. And for major tissue loss, we should treat as many tibial arteries as possible. In endovascular intervention, we commonly do balloon angioplasty. Drug-coated balloon also has its role to prevent restenosis. In SFA, superficial femoral artery segment, we generally avoid putting stents because of that low patency rate and stent fracture. In iliac arteries, we commonly use stenting. In SFA segment, we only put stent when there is a dissection or recoiling. Otherwise, right now, due to that, nowadays, in that extensive calcification, we also have arthrectomy devices also, which we can intervene rather than going for open surgery. In open surgery, if young patient, a long segment occlusion, those are the candidates that are for open bypass surgeries. We always use vein graft because vein graft has that higher patency rate and low infection rate. Whenever, if not possible, if vein is not available, then only go for synthetic bypass. And below the knee, we never use synthetic graft. A few cases that lady, 75-year-old lady with multiple toes gangrene, angiogram done suggestive of mid and distal anterior tibial artery and peroneal artery stenosis. And we did angioplasty, and in that revascularization, we can see good flow to the foot. Along with that revascularization, we also did transmetatarsal amputation, and this is the 2 weeks post amputation. We also offered skin grafting, but they were not ready. This is the 4 weeks post-op, and this is the 7 weeks post-op pictures, and eventually it got healed. Another case, left great toe tip gangrene. In angiogram, you can see that SFA completely occluded, only collaterals can be seen, and distal reformation of the SFA. So we did SFA angioplasty, and post-plasty, we can see that main streamline, good flow in the SFA. Another case, that major tissue loss and femoropopliteal occlusion. So only debridement in this type of cases won't give good result. So along with debridement, we did open bypass repair using reverse saphenous vein graft, and you can see that in the last photo that it got healed without having other further amputation. One more case in which long segment occlusion of femoropopliteal segment and tibial segments. So we did SFA 2 posterior tibial artery bypass, and generally we harvest leg vein from the same leg. If not possible, then opposite leg. And in this CT angio, post revascularization CT angio, we can see the good graft flow and even see the good foot perfusion supplying by that graft. So many other cases where we did revascularization along with transmetatarsal amputation. And these are the cases where previously or at other center they were advised to undergo below knee amputation, and where we reduced level of amputation from below knee amputation to transmetatarsal amputation, because life expectancy and quality of life has its role. And one more case, heel debridement along with revascularization, patient from Kenya, multiple debridements done there, but it was not healing. That's why referred to us. We did plasty, and we can see that it got healed eventually. So change in practice pattern. Initially, open interventions were more. Nowadays, endovasculars. Hybrid is a new norm right now, like in open and endovascular both together. Suppose iliac stenosis and long segment femoropopliteal occlusion, we do hybrid. Iliac angioplasty stenting and same sitting femoral to popliteal bypass. So nowadays hybrid is new norm, but it won't stop after revascularization, because after that also patient had that prolonged healing time, will require footwear and care. Sometimes recurrence of the disease, drop in ABI, and cardiac morbidity and mortality will be always there. So comprehensive care required beyond revascularization in form of wound debridement, infection control, glycemic control, and offloading. So diabetologist, vascular surgeon, podiatrist, ID specialist, wound care, orthotist working together will reduce the risk of amputation by 50%. 80 to 90% limb salvage rate at 1 year post revascularization, and 70% would heal in within 6 months. Reintervention rate are 15 to 30% due to stenosis or disease progression. So challenges ahead are that identifying patient at risk, faster wound healing, keep them healed, because medication stop and foot care and wear is a backseat at our country. So proper education and training required. Our approach at Indovasc Hospital, we have that strict follow-up protocols, footwear modification we are giving, we are educating family members also, and for that cardiac protection and strict glycemic control we are managing. Our follow-up protocol is every third month for first year, then in second year every 6 monthly, and then yearly. So our data at Indovasc that we did in the last 5 years, we did 257 angioplasty and 104 bypass. Our graft patency is 75% and limb salvage is 85%. So take home message, feel the pedal pulse. Even patient comes to you, tell them to remove socks and just feel the pulse. It will hardly take your 1 minute of time. In 10%, dorsalis pedis artery is absent. So even we should have knowledge of anatomical landmark of anterior tibial and posterior tibial arteries. If pulse is absent, even if foot is warm, consider as a ischemia and go for investigation. Even one vessel is sufficient to perfuse the foot, because blockage doesn't mean always require intervention. Medical management also has its role. Consider angiosome consent. Ischemia in diabetes behave differently and more challenging, so we have to also behave accordingly. And amputations carry greater risk of cardiovascular morbidity and mortality, even digit amputations. So critical limb ischemia in diabetics need vascular surgeons as well. So whenever needed or required, do contact us or involve us also. Even we have our National Vascular Day on the 6th August. So join in our noble mission of saving limbs and lives and make India amputation free. Thank you.
Thank you, Rishabh sir. Sir, I want to know that in past we used to that pentoxifylline.
Yes, yes.
Still we are using this pentoxifylline?
Yeah, pentoxifylline also we are using.
And what is the indication for that use of pentoxifylline?
To improve the true-legs formation and collateral circulation. If claudicant, then we are using pentoxifylline and silastazole to improve microcirculation.
Microcirculation for
Yes.
periphery use. Thank you.
But
sir.
after revascularization, when main streamline flow we get, then no need to use Trental or silastazole.
Okay.
Only in the conservative management where we are doing that medical management, best medical therapy, in those cases only we are using.
Thank you.
Thank you.